Thank you, Melissa. So, my name is Arunah. I'm a medical officer with Ministry of Health, Malaysia. I'm also a public health trainee in the University of Malaya. My story today is basically talking about the lessons that we've learned, the journey of translating the global agenda on NCDs into a national strategic plan. Basically, I'll be describing Malaysia's country experience on how we did this. This situational analysis was basically conducted as part of my DRPH studies. The primary objective of my thesis, it was really a quantitative study that explored cardiovascular risks of women in Malaysia. This part of the situational analysis was basically conducted to aid discussions on my policy options or the so whats of the findings of my study. So NCDs, as we know it, are a major cause of premature mortality in Malaysia and globally. We know that 85% of these premature mortalities actually occur in low and middle income countries. So in September 2011, the UN General Assembly convened the high-level meeting on prevention and control of NCDs in New York, whereby heads of states and governments came together to discuss NCDs as an important agenda. Subsequently, in the 66th World Health Assembly, the Global Action Plan for Prevention and Control of NCDs 2013-2020 was endorsed. What this plan really did was it provided a policy option of some sort, a roadmap really for member states to basically achieve the 9 voluntary global targets with a overall target of reducing premature mortality by about 25% by 2025. Dr. Barber earlier mentioned the UN SDGs. This was adopted in 2015, which also recognizes NCDs as a major challenge for sustainable development, which brings us to Malaysia. So Malaysia is a multi-ethnic, upper middle income nation with a high burden of NCDs. How high a burden? Let's look at this. All right, so one way to look at burden of disease is to really look at DALIs. This visual was actually generated from the IHME, Institute for Health Metrics and Evaluation, an excellent diagram really, to show the sea of blue basically that depicts the burdens of NCDs in the country. If you look at our deaths, approximately 73% of our deaths in the country are due to NCDs, primarily due to IHDs and stroke. So food is a way of life for Malaysians. And it's no surprise that our last National Health and Morbidity Survey found that 17.7% of Malaysian adults are obese. And that was a 4-fold rise compared to what we found in 1996. The National Health and Morbidity Survey also found that 17.5% of Malaysians adults are living with diabetes, 30.3% are living with hypertension, 47.7% with hypercholesteremia. Basically, to put it bluntly, if you look at the numbers, 1/5 of Malaysian adults are diabetic, 1/3 are hypertensive, and half of Malaysian adults were either obese or overweight. So it says there that about 22.8%, about 1/5 of Malaysians are smokers, but when you really break it down according to gender, our female smoking rates are about 1%, however, mind you, slowly increasing. So our male, which means our male smoking rates are actually about 45% really. So we've established that Malaysia has a high burden of disease when it comes to NCDs. What Malaysia previously did was we previously addressed NCDs in very fragmented approaches. Prior to 2010, we had basically a silo or a vertical approach. Every disease had its action plan. Every disease had its implementation guideline. There were so many. There was one for diabetes, there was one for hypertension, there was one for cardiovascular diseases, there was one for stroke, there was one for cancer. So there were many working groups that were established. However, there was no platform for coordination really. There was very limited policy guidance also. So none of the working groups that were established to address each one of these, frameworks actually had a national indicator or even a system for monitoring and evaluation of their targets. So fragmentation and lack of coordination were perhaps one of the reasons why that hampered previous work on prevention efforts that really did not see, as you can see from the numbers, that did not really have an impact or a considerable change in our burden of NCDs. So, in Malaysia, so the objective of the situational analysis was really to look at how we developed and implemented our national strategic plan on prevention and control of NCDs based on the global mandates. For this, I looked at available published research with the relevant terms, a qualitative desk review on available policy documents, and expert consult with key stakeholders who were actually involved with development of these integrated national action plan. So if you look at published research per se, there was not much there. In 2014, there was a paper that was published that looked at two major approaches that Malaysia took, one of it being the primary healthcare as a gateway really to look at prevention and control of NCDs, and taking community as basically a partner to tackle NCDs. If you look at policy documents, in Malaysia, the development of the National Strategic Plan for NCD, or basically the NSP NCD, at the end of 2010 was perhaps the most important step for us towards addressing what I mentioned earlier, the fragmented response to prevention efforts and the lack of systematic interventions. The plan was based on global mandates and other relevant information from, we looked at neighboring countries and the local evidence that was available to us at that time. The NSP NCD was developed in 2010 by a Ministry of Health NCD task force that was headed by basically the Director General of Health. The development of this plan had very strong support from the Minister himself. The Disease Control Division was responsible for heading this team. The drafts that were presented were basically presented at various technical committees, and we engaged other ministries throughout an establishment of a high-level interministerial committee, again chaired by the highest level Secretary General of the Ministry of Health. There was also engagements, not much, towards the NGOs and civil society that was done towards the later stages. So the implementation of this plan was facilitated by the creation of a National Cabinet Committee for NCD prevention. So basically taking it to the highest level, involving 10 ministers, and basically that was chaired by the Deputy Prime Minister. When that was approved, the committee consists of 10 ministers. We involved not just health, education, we got the information minister involved, rural and regional development, agriculture, youth and sports. We had human resource, we had the trade minister, housing development, and women and family development. So the main TOR, the terms of reference for this committee, was to determine policies that looked at creating a living environment that supports behavior change really, and of the population in Malaysia, mainly looking at healthy eating and active living. So following the launch of the NSP NCD 2010-2014, the NCDs basically became involved in the 5-year development plan for Malaysia, the 11th Malaysian plan. It looks into realizing Malaysia's goal of becoming a developed nation. The plan actually recognized the double burden of both non-communicable diseases and communicable diseases. There is a clear mention in Malaysia's development plan into looking into provision of preventive healthcare, looking into healthy lifestyle promotion, and also the role of both government, private sector, and NGOs. In terms of social responsibility, in terms of provision of care, health promotion, education, and research. So the MOH strategic plan subsequently, so now we know the NCDs have now been highlighted at the country development level. At the ministry level, in fact, that the Ministry of Health strategic plan that sets the ministry's direction for 5-year period also highlighted the need to strengthen efforts to address the burden of NCDs. So these are the policy documents that, if you can see, that encompasses basically the National Strategic Plan for NCD 2016-2025. The strategic plan is basically designed to act as a framework, really, not just telling you what to do, but it's actually a framework that has many active policies inside it. And the cabinet committee that I mentioned earlier acts like some sort of a medium to assign different responsibilities to different agencies and sectors according to their mandates, with the ultimate aim to achieve set national goals and targets in terms of NCDs. So if you look at this diagram, there is a strategic plan to address active living. There's one for nutrition. There's one for cancer control, tobacco really, and alcohol. And because hypertension is so high in Malaysia, and salt was also mentioned in the voluntary target, the global targets, there is one specific policy to look at salt reduction strategy and multiple policy options to combat obesity. So when you compare the Malaysian policies that are in existence to global mandates on NCDs, the strategic plan was really inclusive of all the scope of diseases, except a little mark there. There is an notable absence in chronic respiratory diseases. However, Malaysia is not alone in this. If you look at WHO's information, many countries have policies and strategies for addressing NCD targets, but quite a bit of countries neglect to address chronic respiratory diseases. According to WHO, 71% of member states already have an integrated NCD policies. However, only 51 covers all the 4 main NCDs, including chronic respiratory diseases. Right. So we've discussed some of the roles and the processes that were involved in developing this national action plan. Some of the challenges and solutions will be discussed in the next slide in terms of the development itself. So far, to really look back at what we've done, there's several positive trends if you see from what I've mentioned so far. So we've shifted away from looking into specific programs to integrated NCD programs. We've now managed to successfully include NCDs at a sector-wide, not just as in NCDs per se, but all over Ministry of Health and other agencies' health plans. We've basically established a high-level committee at the level of ministers and Deputy Prime Minister, which basically acts as a coordination mechanism. Despite all this, there were several issues in terms of implementation. You've got this beautiful plan. There are major issues that in terms when it comes to implementation, such as enforcement, which is big for us, big area of concern for us, and the lack of political will, especially when it comes to interference from, for example, the tobacco or the food industries. So this is, according to the expert consults, some of the SWOT analysis that can be concluded. If you look at strengths, we do have the policy documents. We have the availability of baseline parameters in Malaysia. We have our rolling survey that looks into NCD risk factors that's done every 4 years. The next one will be in 2019. We have, as I mentioned, a high level of interministerial committee. And again, the issue of enforcement is a big issue for us. And all these policy documents that I've mentioned earlier, they're not accompanied by budget and resource allocation. It all comes from pre-existing operational budgets. In Malaysia, we also have an issue with the lack of very strong civil society movement. And like I mentioned earlier, some political commitments are issues when it comes to lobbying by the sugar and tobacco industries. There are very strong industry lobbying in the country. It's worsened by public objections and resistance when it comes to wanting to implement health policies. However, recently, as perhaps some of us are aware, there was a change of political climate in Malaysia. So we use this as policymakers for a fresh buy-in, really, from a new cabinet that convened, whereby there was many pending decisions that were not implemented, that were subsequently approved with the new cabinet. One such example would be, for example, the discussion in detailed discussion on the introduction of sugar-sweetened beverages taxes. So as of the last Cabinet Committee meeting, we've managed to approve the introduction of sugar-sweetened beverages, or SSB taxes, that will be implemented in the country. Another main I think success for us is a change in legislations to include a smoking ban, for example, in open-air restaurants and public areas. So these are small successes that can be implemented through this interministerial committee, which would actually require buy-ins from different stakeholders. So, moving on. This review was, however, limited to just the available national public policies. We didn't look at implementation guidelines at the local level or the legislations. I did not consider the outcome of the policy documents. However, just considered the existence of these policies as indicators of high-level government commitments. And the effectiveness of the overall NCD's policies were also not evaluated. So the lessons learned from our journey is basically, as a result of global mandates, our NCD policymakers were driven to develop an integrated strategic plan. And then they went on to develop specific policies to address the common risk factors. The governance of these policies, it was very important that it was mandated at the highest level. There was strong political commitment at the time of development and national ownership, and a strong leadership from ministry. There was, despite the strength and opportunities, like I mentioned, there were issues in terms of buy-in from other ministries. We struggled to get in the buy-in, especially in terms of education. Childhood obesity, for example, is huge in Malaysia. So Ministry of Education, for example, needs to take and play the leading role. So those are the issues. And to conclude, I think effective implementation of the plan will require us to address all those remaining challenges. Thank you.